Welcome, everybody. My name's Neil Stewart. I'm the editorial director at the Maternity and Midwifery Forum and also of the institutional catalogue that you can get in universities called Matflix. Today, the Maternity and Midwifery Forum is running a spotlight conference supported by Active Iron, but looking at the different ways in which people of Black and ethnic minority, Asian, and others are treated inside the healthcare system, particularly in maternity and midwifery. It's only a few years back that we had the first shocking statistics that revealed maternal death statistics of 5 times more. The health service says that they've now got it down to 4 times, and amongst Asian women, it's 2 times. But those are the mortality figures. A lot more happens and a lot more difference is being discovered as we move forward. And one of the areas of that is in iron deficiency. So we have 2 fascinating speakers to take us through this subject today. And I hope that you will find a lot to take away and discuss with colleagues. Now, there is a chat function in this live stream. Put your name in and say hello and where you're from. And also that's where to ask questions or make comments. If you want to ask a question, I'll put the questions to our 2 speakers. So without any more ado, I don't have to do any warnings about fire drills or anything else. It's the great advantage of online. Let's see if we can make a start. So our first speaker in this morning is Dr. Kiran Rahim. Now, Kiran has worked across many London hospitals and uses her own experience as a mother and South Asian woman to talk about issues relating to women and child health. She's a passionate advocate for child health, health promotion, and for Black, Asian, ethnic minority communities, supporting women to pursue higher education and leadership roles. Her goal is to share her knowledge base by providing tips and medical advice, and you will get a number of those through the course of this presentation. So Kiran, if you would like to start sharing your slides. This is a subject that we have looked at on several different occasions and will return to again. And we're very thankful for the support of Active Iron in making all of this positive. So Kiran, the screen is now yours.
Great. Thank you so much, Neil, for the warm introduction. So hello, everyone. Just a little bit about myself. So as Neil said, I am a paediatrician. I work in London, and I started getting involved in sort of advocating for healthcare, and in particular healthcare inequalities in global majority and Black and ethnic minority populations, just because of my own experience as a mother, firstly, as a woman who accessed healthcare, as a professional who have access healthcare, and sort of the discrimination I felt I faced. And then what I see in my day-to-day work, working with families across sort of different social economical backgrounds, and how that sort of shapes their healthcare journeys. And I think that all of that is really going to inform the talk today, and understanding how women in particular, and those that come from different backgrounds, face inequalities in healthcare. And as Neil said, this is supported by Active Iron, and I've been working with Active Iron for a few years now, and I'll share why in a little bit. So the reason we're talking, so that's me and that's Alicia. Alicia, did you want to say hello now, or do you want to say hello a bit later?
I'd love to say hi now.
Yeah. Why don't you go and say hello?
I'm not sure if they can see me or not. Okay, so I'm the disembodied voice of Alicia Burnett. I'm a registered midwife, and I'm also, hi, there you go. I'm also the founder of Black Baby Loss Awareness Week, and I've been on many maternity and midwifery forum events. Neil's very familiar with me, and hopefully some of the audiences today, and I'm really thrilled to be talking about this particular topic this morning. Thank you. Back to you, Kiran.
Thank you so much. And we are truly, truly really grateful for your expertise that you'll be sharing with us later. So why are we talking about maternal health, and in particular maternal health in Black ethnic minority communities? Well, I'm sure this comes as no surprise to anybody in here, but essentially morbidity and mortality in pregnant women has been a priority for the government in sort of the last decade. We were hoping to get mortality down by about 50%, but actually multiple Embrace reports have shown that we aren't meeting that target. Now, this is the most recent Embrace report from 2023, and it just highlights the statistics that Neil pointed to earlier. And actually, if you are a Black or brown woman, you know this. You don't need a statistic to validate or, reaffirm with the experience that you've had. And many women have had this experience. So what does the Embrace report tell us? It tells us that, this is a 10th report, by the way, and the way that it is produced is that it looks into the care of approximately, I think it's 572 women who died during their pregnancy or in the 12 months following their pregnancy, so in their postnatal period. And this particular report looks between 2019 to 2021. And I think it's really important to say that this looks into the top causes of death. It doesn't necessarily look into inequalities in detail. So what were the other barriers? It briefly touches upon them, but it isn't a detailed report in that sense. So this year's Embrace report tells us that women from Black and ethnic minorities are 4 times more likely to die, and women from Asian ethnic backgrounds are twice as likely to die compared to white women. And this is what this graph here shows on the right. It also tells us that women who come from poorer social economical backgrounds, so more deprived areas, continue to have the highest maternal mortality rate compared to those living in the least deprived areas. And again, this is related to many things, but this is across the board, across the nation as well. So it doesn't matter whether you're living in London or Birmingham or in the Dales. We know that if you are from a poorer background, you are more likely to have adverse outcomes in your healthcare. And what it also tells us that the 12% of women who died, so 12% of the 572 women that they looked into that died, had multiple severe disadvantages. And so that looks into deprivation, it looks into things like domestic violence, it looks into education, it looks into poverty and all the other factors that can influence maternal health outcomes. And I think it's really important to say this, and I say this because I'm a children's doctor, and actually the one thing I always say, and I just, when I write to my MPs or when I'm talking, is that there is no child health without maternal health. And I can't say that strongly enough. Child health comes when women and, mothers in particular are healthy. So what does the child database tell us? Well, this is looking at child death per 1,000 live births. And we know that Black babies in England are 3 times more likely to die than white babies. Asian babies are twice as likely to die. And infant death rates amongst Black and Asian ethnicity groups increased in comparison to previous years, whereas the death rates in parents that were white decreased. So essentially, Black brown babies are dying a bit more and white babies are dying a bit less. And as with maternal health, infant death rates in the most deprived neighborhoods of England are twice as likely than the least deprived. And what the last 10 years, so last year has shown that the inequalities have widened and the death rate has increased in the most deprived areas in comparison to the previous year. So things are just getting worse. The government had a plan to reduce the inequalities, but actually the evidence is going in the opposite direction. And that's why we're going to talk about, look into a little bit later. So before I go on, I want to share a story. So why are we talking about maternal health? So I'm a pediatrician. I am also a mum. I have 3 children, and I have probably accessed maternal healthcare services multiple times in the last years. I have 3 live births, and then I've had 3 pregnancies at different stages of my 9-month pregnancy. And I talk about iron a lot because in pretty much every single pregnancy that I have experienced, I have had symptoms related to iron deficiency and feeling low, and then having those concerns dismissed as this is just pregnancy. People feel tired, women feel tired all the time. And despite me advocating for myself as a professional, as a doctor, I've had a lot of those concerns dismissed. And the next couple of slides I'm going to share are real stories from women that I have had the pleasure of speaking to about how they have experienced maternity services. And I say this as a trigger warning because some of these stories are quite awful. And so just please read them with a little bit of sensitivity, and if you need to, take some time away. So I'm going to read these out because I think it needs to be said. So this is these are all patient stories. So this is a woman who, when I said, do you want to share with me what your experiences were with maternity services, said, I was begging for a blood test around 34 weeks in the UK due to severe itching. By 36 plus 4, I had been awake for 2 nights crying from discomfort, got given some Acris cream and sent home from the waiting room after waiting 4 hours with a then 15-month-old toddler. They kept saying there is no one to see me until my white husband left work, and as soon as he heard I was denied medical attention, he marched into the MAU and demanded I get seen. Literally moments later, someone was miraculously free. Of course, then it turns out I had obstetric cholestasis. I'm sure it triggered my slightly preterm labor. People of color are at an increased risk of this anyway, knowing it can cause stillbirth, and I was made out to be dramatic. My baby was born about 12 hours later, and I still needed the Urso, which is a medication, for a couple of weeks postpartum. So that's the story of one woman. The other stories are myself and my white colleague fell pregnant at the same time. Our maternity care was under different trust. She had suspected family history of preeclampsia, whilst I have a family history of preeclampsia. She was put under a consultant purely for this reason and gave birth to her baby girl with no complication. I, on the other hand, complained of symptoms of preeclampsia, and my husband was pulled aside and told I was overreacting. My son was stillborn at 25 plus 5. I had a stillborn at 36 plus 6 days. I went in every day, 35 weeks and 6 days, leaking water. They never once scanned me, and they never caught gestational diabetes at 35 weeks. I still suffer till today. My pregnancy, I had 5 afterwards. They took extra care, but this lived with me the day when my baby stopped moving, sat in a waiting room. I can hear them talking about their Valentine's Day, wiping their hands in the nurse's outfit from biscuits crumb. My baby was dying, and maybe you could have saved my baby if you weren't busy chatting and having biscuits. Sad. I'm not going to read the rest of them, but I'm going to leave these up for a moment for you to have a read, just because I find them quite horrifying to read myself. So I will give a moment for everyone to read this, and then I will move on. So I'm going to move on. We will be sharing, I think, these later. So if anyone wanted these slides, I'm happy to share them. You can reach out to me directly. So why am I talking about this? Now, this obviously is the severe end of people experiencing maternity services. So, these are women who have lost babies or have had less than adequate care. And I think it's really important to highlight this because as people who deal with pregnant women, and I deal with pregnant women as well, I counsel them if they're in preterm labor, we all have an opportunity to provide holistic care that makes women feel listened to. And that's really important when we look at the statistics that tell us that Black and brown women are at a disadvantage and they're not getting the same care. Because it leads to outcomes where they lose their babies or have poor experiences, which then impacts how they reach out to healthcare professionals in the future as well. It also impacts how they have relationships with healthcare professionals going forward. So doctors, midwives, health visitors, community nurses, and all of these experiences are shaped by every single encounter with a healthcare professional. Now, we're talking about iron in particular in this sort of next half an hour, because a lot of women present with symptoms of iron deficiency, as well as iron deficiency anemia and low iron stores. And what we have found over the years is that they are ignored. And we will come on to why iron is important later, but I just wanted to share some statistics with you and some stories about how iron affects women, and particularly pregnant women. So there are 2.1 billion people living in the world with an iron deficiency and 1.1 billion with iron deficiency anemia. It's essentially the most common form of malnutrition, affecting up to 1 in 4 women. And this is even when they're not pregnant. So this is just regular women who, anyone above the age of 18, and it affects low, middle and high income countries just the same. And I think it's really important we understand this, because women generally, and women particularly of childbearing age, require up to 3 times as much iron as men do. So women have a requirement that is almost 15 milligrams, whereas men is around 8.7 to 9. According to a recent study in the US, and there aren't that many. So the first thing to say is we actually don't have much evidence, because a lot of the evidence that we get is based on white populations and European populations. We don't have much evidence that comes from Black and ethnic minority women or global majority women. So essentially what this research shows is that in the US, Black pregnant ladies are more likely to have iron deficiency anemia than their white counterparts. And between sort of in the last decade, the prevalence of anemia amongst Black patients has increased 100%, thereby widening the gap in sort of the healthcare outcomes for them, because we know if you're anemic, it can have adverse outcomes for both mum and for baby. This is also replicated in the UK and Ireland, where studies have shown that minority ethnic pregnant women, so those of an Asian, African or Caribbean background, are more likely to have anemia. And African women in particular had the lowest hemoglobin levels going into pregnancy, and indeed in the first trimester of pregnancy. So the importance of iron at each stage in life. So we are predominantly talking about pregnancy, but actually iron is important throughout. So you need it in your preconception ages, in your postpartum, and indeed in perimorph. So your iron requirements change. So essentially in preconception, things that can influence your iron stores and your iron need is things like your period, your diet, if you have menorrhagia or irregular heavy periods, if you are particularly sporty or active, because we know women that engage regularly in sort of heavy exercise or stamina increasing exercise have increased iron demands. And then things like absorption, there are issues with the current iron that we use in pregnancy and otherwise, and how it causes symptoms in women and men as well. And then pregnancy itself poses a particular problem for iron. So we know when women are pregnant, the demand for iron increases, doesn't it? So you've got essentially a growing placenta, you've got a baby, and you've got increased maternal red cell production, and all of that is based on iron. And then if you are pregnant multiple times, that can have an effect on multiple times in your life. And then postpartum, breastfeeding also has increased iron requirements. And then you get into perimenopausal in your life. And then again, things related to diet, exercise, heavy, irregular periods come into play. So essentially, there is a foundational need for women over about 30 to 40 years from preconception right through premenopause, where their iron requirements change, and we need to support these women, particularly when they are around pregnant, when they are thinking about pregnancy, and indeed during pregnancy and postpartum, because of the requirements, but also because how it affects them, their energy levels, and how it also affects their baby. Sorry. So the thing to say is that iron absorption and iron intake has been a real issue in sort of maternal health care, with lots of women complaining about compliancy and how they deal with the iron. We know that the iron supplements have lots of issues such as heartburn, constipation, and so it really stops women taking iron. And it's not until recent years that we have alternatives, which are things like IV iron, to help them deal with iron deficiency. So just to recap, pregnant women during pregnancy, the amount of blood in your body increases about 50%, and as does the requirement for iron, and that's to support your increasing placenta and the red cell turnover. Up to 20% of women who are having regular periods are deficient in iron, so even before they get pregnant, because of period and period-related blood loss. Once a pregnant,
That mean?
iron alone will not replenish levels. And I think this is really, really important, because this is one of the advice that I was given, and I know multiple women are given, to just eat better. And pregnancy is one of those times where you really do struggle to eat. And then around 37% of pregnant women suffer with anemia, which increases to 40% postnatally, and that's likely due to peripartum loss. So I think it's really important to talk about anemia, because everybody sees anemia in a different way. And I remember when I was advocating for myself, I really, really struggled to be taken seriously. I'm someone who, when I'm not pregnant, runs about 5K about 5 times a week. I lift weights. I'm pretty active. And I remember going to my GP and saying, I'm really struggling to go upstairs. I'm getting short of breath. I feel exhausted. I'm like napping for like 7, 8 hours a day. I was really, really tired. And my GP said, oh, but your hemoglobin is fine. Your hemoglobin is fine. And I requested, and I said, can I have iron studies? And he said, oh, we don't need to, because your hemoglobin is fine. And a lot of it comes down to hemoglobin, but actually hemoglobin is not the full picture of iron deficiency. And even when I got to hospital, in my booking, when I was having chats with my midwife, then it was very much hemoglobin is fine, computer says no. And in the end, I just went around the system, because I'm a doctor, but not everyone can do that. And so iron deficiency is a spectrum, and it's a progressive process in which iron stores first become depleted, and then eventually you get iron deficiency anemia. So you can see it's a spectrum that starts from normal storage of iron and normal transport iron, and then you begin to get deficits in your storage until you get to iron deficiency without anemia, and then eventually you get iron deficiency with anemia. And I think it's really important, if you look across the bottom of this, across the board, it's normal hemoglobin, normal hemoglobin, normal hemoglobin, until you are actually anemic, in which case the hemoglobin is low or low normal. And I think that's the problem we have with most women, that our hemoglobins are the last things to fall, but actually not everyone checks iron reserves. And iron reserves, once they start depleting, women can become symptomatic from here. So from iron depletion all the way through to iron deficiency anemia, women can experience symptoms of iron deficiency with or without anemia. And I think we are very fixated on here as healthcare professionals, and that's where a lot of education needs to happen. I'm now going to pass over to Alicia to take over the talk.
Thank you so much, Kiran. I was absolutely fascinated listening to you. I'm going to attempt to share my slides. Now, has that worked? I believe so. Hold on a second. I always struggle with this. Okay. Okay, that looks okay still.
That's it.
You can see everything? That looks fantastic. Great. Yes.
Off you go.
Okay. So we've heard from Kiran. I'm going to go over some of the consequences of low iron status for mum and for baby. So low iron during pregnancy is associated with several complications for both mum and baby. So for baby, you're looking at things like a risk of perinatal and neonatal mortality. So sadly, loss of life, low birth weight, preterm birth, and also in cases of severe infant iron deficiency, there is a likelihood of motor, social, emotional, and neurophysiologic developmental delays. And for mothers, there's an increased incidence of postpartum fatigue and depressive symptoms, and infant iron deficiency in the first 3 months of life. So it's quite a chronic condition. I'm going to share a little bit of my own personal experience of my maternal experience of having severe iron anemia. So following the birth of my daughter, I experienced a huge postpartum hemorrhage, and I suffered with the effects of iron anemia deficiency for about 6 months following the birth of my daughter. So I'm actually really passionate about this topic, and I do know personally the experience of having had the effects of iron deficiency and the impact it does have on your life and your ability to care for your baby. Every midwife should be giving women dietary advice, and that dietary advice includes how to improve the iron intake through dietary changes. So there are sources of iron that come from food. So if you have heme iron, which is found in red meat, fish, and poultry, and it's absorbed much more readily than non-heme iron. But as midwives, we also need to know about sources of non-heme iron, because we do care for women that are vegetarian or vegan or just don't consume meat. So sources of non-heme iron include pulses, legumes, so things like lentils, nuts and seeds, dark green leafy vegetables, dried fruit, fortified cereals. But however, non-heme iron is less well absorbed, and it's important that we share this information with the women that we care for. So around 95% of dietary iron intake is from non-heme iron sources. So that does mean that women that are vegetarian or vegan or don't consume meat products are more at risk of iron anemia deficiency. And vitamin C also greatly enhances the absorption from non-heme foods. So it's great to advise women that when they're having a source, when they're consuming a source of non-heme food, non-heme iron. Sorry, I'm really, really nervous. I don't know why. Kiran was so flawless and so professional. I'm here wittering on. I'm going to calm down. It's a really good
Great, Alicia.
It's a really good tip to share with women that if they just have a glass of orange juice or something that has a really high concentration of vitamin C when they're consuming food that has that is a non-heme iron source, it does increase absorption of the iron from that food. Okay, current guidelines. This is another thing that we as healthcare professionals need to be really, really up to date with. So what is the definition of iron deficiency anemia? So iron deficiency anemia can be defined as having a HB of less than 110 grams per litre in the first trimester, less than 105 grams per litre in the second and third trimesters, and having a HB of less than 100 grams per litre in the postnatal period. Routine care should be that iron levels are checked at booking, so at that first appointment between 8 and 10 weeks, and then checked again at 28 weeks. It's a really good idea to let women know that this is going to be happening around 28 weeks, because it can come as a bit of a shock when they attend their 28-week appointment and you come out with your venipuncture kit. So just letting them know that you're going to be doing it and why you're doing it is really important. And women that are at high risk of iron deficiency anemia should be started on prophylactic iron supplementation or have their serum ferritin levels checked. Kiran brought up the point of serum ferritin a few slides ago. It's really important to look at the whole picture. Telling a woman that is symptomatic of being anemic, that your HB is fine, this is just a normal pregnancy symptom, can be really dismissive, and it invalidates their feelings and their very real concerns. So you should look at the full picture and includes looking at their serum ferritin levels. Women that are at higher risk of iron deficiency anemia during pregnancy include women that started off with very poor HB or iron status before they became pregnant. They have a previous history of anemia, or if they have a pre-existing blood condition such as sickle cell or thalassemia. They're less than 20 years old. They have some sort of dietary deficiency. So an example is having a condition such as celiac disease and things like that. Again, it's mentioned here, they're vegetarian or vegan. And if they have a very short pregnancy interval, one of the reasons that we recommend that women have at least 18 months between pregnancies is that it gives their body a chance to recoup and rejuvenate and regain their blood, the iron stores that they lost during their last pregnancy, and specifically following their pregnancy when they have the blood loss after birth, and if they've having a multiple pregnancy. Now, an important thing to note, however, is that iron supplementation should not be routinely recommended for all women, because then you put women that do not have an issue with their iron levels at risk of having excessive amounts of iron, and that is associated with an increased risk of thrombosis, so clotting. And we don't want to create a problem that isn't already there. Okay, so just a few recommendations on dosages. So NICE recommend 65 milligrams of elemental iron 2 to 3 times a day for 3 months after the deficiency has been corrected. Very often, we prescribe iron, but we don't tell women that you need to keep taking it even after the deficiency has been corrected. The British Society for Haematology recommends 40 to 80 milligrams each morning, and they recommend that women at increased risk of iron depletion or who have ferritin levels below 30 micrograms per litre should be offered 40 to 80 milligrams elemental iron daily. And they highlight that further research is needed to determine the optimal dose of oral elemental iron. The CDC recommend 27 milligrams of iron daily in pregnancy, and the World Health Organization recommend 30 to 60 milligrams. Kiran mentioned earlier, and I mentioned earlier, that iron tends to be poorly absorbed and it tends to be poorly tolerated, which leads to poorer compliance. So poor absorption, most oral iron is poorly absorbed. This causes inflammation and oxidation in the gut, resulting in negative gastrointestinal side effects. Women report flatulence, constipation, generalized stomach pain, and it really puts them off taking the iron. So stomach pain, nausea, constipation, diarrhea, and that results in up to 50% of users poorly complying with taking their iron. It results in treatment failure. Okay, I like this diagram. It's really, really helpful. So standard oral iron causes gastrointestinal disturbances, which results in non-compliance, and it results in a continued iron deficiency that actually gets worse as pregnancy progresses. It's really important that we emphasize that iron deficiency anemia has enormous health implications for both mum and baby. It's important to be honest. I feel like sometimes iron deficiency anemia and iron supplementation is almost dismissed as being not that important. If you take your iron, that's great. If you don't take it, so what, it doesn't matter, but actually it really does. And the higher the dosage of the iron treatment that a woman is on, the increased side effects, the worse the side effects are that they experience. So the worse the side effects are, the more likely they are not to comply with the treatment. And that results in potentially a mother having to have IV iron infusions. Preventative supplementation is key from preconception to the 4th trimester. So what can we do about this? We can persist with traditional iron supplementation, knowing that compliance is poor because of there's poor absorption, and it creates side effects which result in poor compliance. Or we can educate ourselves about potential alternatives. And one such alternative is active iron. I learned about active iron maybe about a year ago, and I wish I'd known about it sooner, because I was one of those women that complied very poorly with her iron treatment. And that's why it took me about 6 months to recover from my blood loss. So active iron is a groundbreaking, patent-protected iron product, where ferrous sulfate is wrapped in a whey protein carrier together with short-chain fatty acids. The unique formula protects the iron from oxidation in the stomach and then delivers active iron to the most active site of absorption in the small intestine. Basically, the way they formulated active iron is that it's coated so that it gets to where it needs to get to, so more of the iron is absorbed. And it also reduces the gastrointestinal upset that I mentioned earlier. It's kind and strong. So iron is absorbed twice more efficiently than ferrous sulfate. It's 6 times more likely to be well tolerated, with less gut irritation compared to other oral iron. 4 times better compliance. This is really important. We know how important it is that women take the iron that they're prescribed. We need to communicate that. Although we're bound by specific rules and regulations, we can't directly recommend anything, but we can recommend that they look at particular potential alternatives if they are struggling to take the iron that is prescribed for them. But compliance is 4 times better than other oral iron, making it more likely for them to continue taking the product. There's a 94% increase in iron stores, ferritin, within 6 weeks. I can't tell you how beneficial that would have been for me. 6 weeks compared to 6 months, that's huge. You have more energy, you're not sleeping all the time. I didn't get out with my little girl until she was about 6 months old because I was that exhausted. So this really would have changed my life. Hemoglobin levels are normalized in 75% of patients with anemia over 12 weeks. That's with a dosage of 50 milligrams, 2 capsules a day. And there are huge benefits to women's energy levels. There was a significant improvement in energy levels in the overall group over the study period. Seriously, we're talking about life-changing effects in the postpartum period in particular. Throughout pregnancy, preconception, yes, but this really would have made things so much easier for me in the postpartum period. Currently, Active Iron is conducting a clinical study. So it's partnered with Ulster University on a study to be undertaken in pregnant women. And the aim of the study is to investigate effects of prophylactic iron supplementation on iron status in pregnant women. So the patients will be assessed at multiple time points throughout their pregnancy, at 12 weeks, 28 weeks, 36 weeks, and at delivery, where they'll be taking a sample of cord blood. Kiran spoke earlier about the experiences of Black and Asian and minoritized women during their pregnancies and childbirth and the postpartum period, and how they feel dismissed, invalidated, and minoritized, further minoritized. So we wanted to share a bit about how we can empower our clients to advocate for themselves. And so we're sharing with you these steps from 5 times more. If you're not aware of 5 times more, Neil mentioned at the beginning of this session that not so long ago, Black women were 5 times more likely to die during the perinatal period. So 5 times more were founded in 2019 to raise awareness of this statistic and to campaign for improved outcomes for Black women and their babies. So their first step of advocacy for expectant parents is to speak up. Encourage the people that you care for to speak up if they feel that something isn't right. And if they are, it can be really difficult to advocate for yourself when you're speaking to or engaging with healthcare professionals. You can feel very intimidated, but it's important that they don't stay silent. They need to find an advocate, which can be their partner or somebody external to them. It could be a doula, it could be, or another healthcare professional or social care professional that they trust, or just a trusted friend. And it's also okay for them to seek a second opinion. We really need to be less defensive when people that we care for don't agree with what we have to say or would like a second opinion. And we should also always invite them to seek that out. And it's important that women and birthing people trust their gut. We are healthcare professionals, yes, but women are the experts in how they feel. And we should also always encourage them to listen to their gut feelings and their instinct. Encourage women to do their own research and to document everything that happens in their appointments. Thank you.
Thank you very much, Alicia. And it's hard to know where to start, really. So let's start at the beginning with the experience of, if you like, discrimination that you faced and were described rather shockingly in some of those case studies. What struck me, and we've seen this at some of the big maternity and midwifery festivals, we did a big session on birth trauma nearly 8 years ago, and we were very surprised that the whole conference tried to go to the seminar, and we had to run it again. But what we were hearing was not just that professionals were concerned about the experience that the mothers they were looking after were having, but they were describing their own experiences, as both of you have described, that having professional knowledge and professional experience the system just seems to roll forward as though it's not listening to you. Alicia, is that your experience?
Yes. I should not have been sent home with the HB that I was sent home with. I couldn't cope. And I did say I don't feel right. I can't even hold my baby. Nobody listened to me. I should have been transfused with further blood before I was sent home, and I wasn't. I was sent home in an unsafe state. So
And
yeah.
did you know that at the time from your own professional experience, or were you just being ignored as they didn't recognize your symptoms?
They didn't recognize my symptoms and they just wanted me out of the room.
Yeah.
As a midwife, you tell women what the symptoms of iron deficiency, anemia are. You're going to feel dizzy, breathless, but when it's happening to you, your legs don't work. You're weak. And a baby that weighs 3.2 kg, you can't even carry safely. It's not safe for you to get in and out of the bath by yourself. It really is debilitating. And we really do need to listen.
Okay, and Kiran, I mean, as a pediatrician, your experience seems to me to be quite extraordinary, that you didn't feel listened to.
No, I wrote a complaint, Neil, to my GP practice and to the midwifery department that I worked in, because how is it that we, Alicia and I, as healthcare professionals ourselves, how are we having to fight the system? And then what hope do we have for lay women who aren't healthcare professionals, who don't know what the system is, who don't know what they're looking out for? And on one hand, we say we're here to empower you, we're here to listen, we're here to support you. And then everything that we're hearing from statistics, everything that we're hearing from women is completely the opposite. And it's really interesting when people say they're shocked or they are, they find these statistics alarming, because Black and brown women have been saying this for years, for decades, even prior to these studies coming through. And much like Alicia, I was iron deficient throughout my pregnancy. And as we talked about, most women going into pregnancy are iron deficient as a result of either diet or, predominantly their periods. And then I remember when I gave birth to my last baby, who wasn't that long ago, 2 years ago, and being like, oh, I think, they documented I'd lost like 600 mils and nobody thought to check my blood levels before I was going home. And I was like, I think I need a blood test before I have to go. And they were like, oh, I'll check with the doctor. And I was like, no, I'm asking you to do a blood test. And if you read the stories that I shared, it's that idea of not being listened to and not being sort of heard. And it's really interesting because I also work with families when they come into my A&E or when I see them. And it's really hard to then engage with mothers who have been through a system for 9 months where they feel unheard, they feel not listened to, and they feel gaslighted. And then they have significant birth trauma, because when I come in, I have to build that trust. I have to say that I hold you and your baby at the forefront of everything I'm doing right now. And it's really hard sometimes to get past that birth trauma, because what it does is it feeds health anxiety, which then impacts the child. It impacts how they access other healthcare professionals. And then it has this effect going forward. And we know this, we know women that experience birth trauma and their partners have a lot of healthcare anxiety. They do not want to engage with healthcare professionals. And then are we doing a child an entire future of disservice?
Now, in the chat, Nicola Tilston says all women receive a 28-week HB check, but from your presentation, you're saying there should be one at 12 weeks as well, and that those checks are not always interpreted properly. Kiran, is that, just explain the 12-week check as well as the 28-week.
I think Alicia can probably do that better. She's a midwife, but actually you should be having a booking visit where you have a booking bloods. That is a whole part of your booking in process.
Alicia?
I do think we should be having more HB checks, and that we should be looking at them in conjunction with ferritin levels, because by the time you get to 28 weeks, if you've already started off iron deficient before you got pregnant, at booking, it may or may not be picked up, or you might be borderline, so they'll leave you. And then you'll experience, which is normal physiologic hemodilution throughout your pregnancy. By the time you get to 12 weeks, you're starting to feel not so great. By the time they see you at 28 weeks, they then put you on iron supplementation, which you may or may not comply with. By the time you get to your birth, God forbid you do have a postpartum hemorrhage, we need to be checking in a bit more regularly when it comes to this. That's my personal opinion for sure.
And this is also where health inequalities come into place, right? So if you are from an affluent area in a trust that has a bit more money, you are going to be having a lot more checks. You're going to be having bloods. You're going to be having more scans. You're going to be having more midwifery appointments. If you come from a socioeconomically deprived area, everything is rationed, including visits. And I know lots of trusts where they do the bare minimum. And I say this as a pediatrician that works in them, and these are trusts that are highlighted over and over again. So I think this is not about, remember, guidance is there as a guidance. It's not written in gold that this is what we have to do. It's guidance for best practice. That doesn't mean you can't improve on that practice. And this is something that people should be taking up locally in their networks, in their sort of maternity meetings, the perinatal mortality, morbidity meetings, because the numbers that we look at just look at death. There is so much more that happens in pregnancy that isn't death related, things that happen with relation to birth trauma, with injuries. These are all just as relevant. Mortality is not the measure. The measure should be how satisfied women are with the care they receive.
And we've got another comment here from Rebecca Jane Watson. She said, I wonder, therefore, if ferritin should be routine at booking. But Alicia, were you sort of cautioning against taking a universal approach, that it had to be a properly analysed approach, and that you shouldn't necessarily medicate all women? Or what's your view?
Yes. I do. We certainly shouldn't be giving out iron supplements to every woman as routine. It's only in response to a detected deficiency, but that we need to look at HB and ferritin levels together, because HB can be fine and you still feel absolutely rubbish. Yeah. And then if you don't respond to that woman telling you that she doesn't feel great because her HB is fine, she feels dismissed, doesn't trust healthcare services, and won't engage.
Now, Nicola's come back on again. She said, is some of this down to NHS staffing levels? Was the practice better in previous years? Was there more time? Or is this the sort of increasing turnover throughput, sort of itemization of contact between women and the service, rather than a kind of continuity of care that the profession aspires to? Kieran?
I think it's a mixture of both. I think you have hit the nail on the head. So if you look at what the research tells us, is that all inequalities across all healthcare systems in the last 10 years particularly have widened, and they've widened as a result of just the natural processes in things like staff resources and generally resources being poor in the NHS. But we also know that COVID has really impacted healthcare, and inequalities have widened particularly since COVID, and that's across all services, not just maternity. So I think we do have to take things with a bit of pinch of salt, that yes, some of these things are historic, but what women are saying, they've been saying for years. And I don't think anyone aspires to provide poor care. I think there are systems in place, there are cultural barriers that come into place. No one walks into maternity or obstetrics or pediatrics saying, I'm not going to do a good job today. But there are staff pressures, there are performance pressures, there are cultural pressures, bullying, racism. We all know all of these things exist, and it's about having the courage to call it out on a hierarchical level. We know the NHS is hierarchical, and it has to be a top-down approach. Expecting people at the bottom to raise the voice we know that doesn't work. Change comes from top down as much as it comes from bottom up.
Can I ask a quick question about iron deficiency? As the childbearing part of the population gets older, does that change the profile in relation to iron deficiency? Are younger women in a better position or more at risk? are older women? Is it a consistent thing, or does it increase with age as we see the average age of childbearing going up? Kiran?
So it's across 40 years roughly. So women from childbearing age until they are postmenopausal are at an increased risk of anemia with or iron deficiency with or without anemia. That will be impacted on, it's on a woman to woman basis, on the heaviness of their period, on the regularity of their period, how early they're going to perimenopausal symptoms and indeed menopause. It will also be impacted how many times they are pregnant, whether they choose to breastfeed, how long they breastfeed for. So these are all things we need to take into account when we are providing a holistic approach to women who are childbearing and then postmenopausal. So it's not age necessarily that increases it, but as a woman, you are roughly at risk of iron deficiency for, say, 40 years on average.
And Alicia, just expand a bit on the importance of diet, and particularly the interaction of vegetarianism. I mean, amongst the young women I know, I would say that 50% of them or more are now practicing vegetarians or vegans. Just describe again the kind of advice or approach you would take to somebody on their diet.
It's important to know if somebody is vegetarian or vegan, for example, because non-heme sources of iron are less readily absorbed by the body. So you receive less iron from those food sources that are not, you receive less iron from non-meat food sources. But that's not to say that you should make them feel hopeless about it. Just do your Googles and figure out which non-meat food sources are rich in iron. So, for example, I love to plug lentils. I love lentils myself. They're easy to make, they're easy to prepare, they're rich in iron. Things like your dark green leafy vegetables, your kale, your broccoli, things like that. And you can also get foods that are fortified with iron as well. So your almond milks and your things like that, your dairy substitutes can be fortified with iron. It's just reading around about what's out there and being familiar with the different lifestyles. You're not going to know about everybody's lifestyle. Everybody's different, but just having that generic information to hand to signpost them to.
So Elizabeth's asking a question, which I think you've partly answered, that you wouldn't recommend ferritin to booking at all levels, but you would just at-risk groups. But is everyone at risk? Is it not? Are you looking at the profile of the individual woman, or are you saying that Black and Asian women are, as a group, more at risk? Does that make sense, Kiran?
Yes.
You are saying they're at-risk groups. They should be regarded.
So this research tells us that Black and brown women are more at risk of iron deficiency anyway. And then women generally are iron deficient, whether you are Black, brown or white, you are generally iron deficient. So I think this is where coming in when you are booking and you're talking to a woman, it's about seeing her as an individual and saying, you know what, can I ask? We ask about periods. We always say, when's your last period? And we ask a bunch of ridiculous questions sometimes, but we never ask, how heavy are your periods? Do you feel tired? Do you have symptoms of iron? And it's just one simple question that we could all ask that would really change the way women then go and access healthcare. And I'm not saying spend 20 minutes, just it's really interesting. Like, I've been asked a whole bunch of questions. That's always very interesting. You know, am I related to my husband other than marriage 1,000 times? And that question is asked every single visit that I go into, but I'm not asked about my iron symptoms. I'm not asked about my urine symptoms. So it's just standardizing the care and sort of facing our own biases a little bit. I think as healthcare professionals, we all have them. And I say this as someone who's had to unlearn and learn so many things over the last couple of years.
Well, we've had over the past sort of 4 or 5 years this huge discovery moment about the menopause in women's life. In the past 6 months, right up to parliamentary select committees, there is increasing, if you like, public discovery about the impact of very heavy periods and some conditions like the newsreader and others that they suffered. Why do you think these questions are not asked more directly? Is it felt to be intrusive? Do women not volunteer it? you know, if it is such a likely indicator, I think you said in one of your slides, Kiran, it's a taboo. Are we trying to break another taboo around that? Go to you, Kiran. Do you think it's a taboo that has to be tackled? Women talking about their periods to their midwife as an indicator, or is it a reliable indicator?
I think periods generally in society are a taboo, and I think women aren't empowered enough, even when they're accessing, you know, primary healthcare services, to forget midwifery. So by the time they get into their childbearing years and they get into, you know, whenever they're having their first baby, they've already faced a level of what they think is appropriate chat around periods. And, you know, lots of employers don't have period friendly policies. They don't you know, they don't have access to period or sanitary products and stuff in their bathrooms. So I think there's already a taboo in society which does filter into healthcare. And it's really interesting that we place onus on women to say, you know, well, actually I have heavy periods. And I will always say that to my healthcare professional. I am a healthcare professional. I know to say that. We can't expect women to know what they don't know. And in the same way, we don't expect men to know what they don't know. And that's why we run national campaigns to educate people about what X, Y, and Z are. And I think when it comes to women's healthcare, we know that there's been systematic non-funding and under-resourcing in our policies that shape women and childcare. We've known this for almost a decade now. And this is why I think it's really important that healthcare professionals also show up and, you know, and take an interest in the politics, because politics influence policy and policy drives funding and access to healthcare. So that's my 2 cents. I don't think the onus should be on women, but we should be asking relevant questions, and periods are relevant to pregnancy, particularly in the context of iron deficiency and symptoms. You know, what's the most common symptom women complain of? Being bone tired when they're pregnant, and everyone just says, yeah, it's just pregnancy. Yeah, it might be, or she's severely iron deficient, you know, and it's our duty to make sure she isn't.
It's interesting that, so the other, if I can call it, this wave of discovery that's going on is about birth trauma. And what, Alicia, you were describing, I mean, most of the birth trauma stories have focused on maternal and stillbirth. But in all the big inquiries, there's been a long tail of what is described as birth trauma. That is, mother and baby may have survived, but the experience has been extremely traumatic. And when something can go on, and the way you were feeling, Alicia, for 6 months or more, that feels traumatic, and it affects how people then, you know, view their experience of childbirth. Now, what was striking about, I mean, the statistics that you put up on Active Iron was going through all that list of the traumas that could be reduced, the times that could be reduced, compared to using, if you like, the sort of standard approach of giving out iron that's perhaps not absorbed in the right way. I mean, why is the service so slow to take up these kind of points? Have you got, and why is it not, you know, much tougher on the kind of prescribing lists and descriptions of how you get the iron to the right place? Alicia, do you have about the power of reducing trauma, first of all?
Okay, that's a big question, Neil. I'm glad that birth trauma is getting the attention that it is getting. It deserves it, because birth trauma doesn't, as you said, doesn't always mean that either mother or baby or both didn't make it. They both didn't survive. It can be not feeling listened to. It can be being coerced. It can be not having your support persons around you because of A, B, or C policy. It can be anything that makes you feel dehumanized and as if you don't matter or that your baby doesn't matter. It's anything that makes you feel that you're not listened to, because the way you're treated when you're giving birth, it stays with you. They say that the pain of childbirth does go away and that you forget. I don't believe you forget. I believe you compartmentalize it somewhere very, very far away so that you can function. But birth trauma, the indignities that you suffer at the hands of people that perpetuate obstetric violence and birth trauma that stays with you, and it can affect your everyday, day-to-day life and your further pregnancies. It can affect your decision to have more children or not to have more children. And your second question, why does it take so long for things like active iron to become commonplace or common knowledge in maternity services? Everything takes such a long time. Everything takes such a long time to filter down into practice, which is why it's great that people come to things like this so they can pick up these nuggets of knowledge and share them. Everybody knows that compliance with iron supplementation isn't great. Everybody knows that. And we expect women to chug down these 6 tablets a day, knowing that they're not going to do that because it gives them a tremendous tummy ache and constipation, and they're already suffering the effects of progesterone that bring along those side effects anyway. But we just keep doing it because it's policy. So keep coming to things like this and learning about things like this and sharing with the women that you care for.
Okay, so as we come to the end of this programme, Kiran, what's the sort of final message that you would send out, both to professionals and to women? Alicia had her list of speaking up, finding allies, follow your gut. I'll give the last word to you, Kiran. What's your message, your shout out to the service and then to women?
I think I will speak to healthcare professionals to say that when you are designing services and thinking about women, you need to include them in the decisions that they make. So we know going forward, the NHS needs to be co-collaborative with patients. So having patients actually inform the care. And that means you hold regular forums, you listen to the women that have been through your services, you ask them about their experiences, and you use those experiences to inform future practice, because that's how it should be. We are in the profession of learning, and learning applies to us first before we educate others. I will also say that when it comes to maternity services and women listening, is listen to what they say and act upon it. So it's no good saying women reports feeling tired and then not doing bloods and not doing your basics. And as a woman, if you are listening to this, you always have agency. And if you feel like your agency has been taken away, you don't have to see that healthcare professional again. It doesn't have to be blood. It doesn't have to be in bad blood. You're just allowed to say, I'd like a second opinion. I'd like to speak to someone else. Just like in real life, sometimes you meet people, you don't gel with them, for whatever reason. And that also happens in healthcare. You meet people that aren't perhaps the people you get along with, and that's fine. Ask for someone else. And we as healthcare professionals should not be offended. Sometimes it's just the way it is, and people are allowed to make decisions about their body and about their healthcare. That's okay.
So a big thank you to both Alicia and to Kiran. Everyone who's watching and everyone who signed up will get a full copy of all of this presentation, so you can revisit it and catch up on the points that you wanted to follow through. The slides will be made available, and we've had a couple of questions about whether or not, Kiran and Alicia, you can provide some references and things, and we can put that into the package that goes out. What is the research background? And a big thank you to Active Iron for supporting this, and quite interested to hear, and no doubt we'll be back when some of the results from the Ulster study come out. But I think a big revelation of a major issue, which even surprises an old lag like me, that the service hasn't got completely on top of it, but definitely something that, if it's not tackled, will increasingly be the source of complaints as women in particular, become aware that perhaps this is not as exceptional as they thought it was. So a big thanks to Kiran and to Alicia. And that's all from us here. We'll have future conferences and programmes on maternity spotlights from Matflix and from the Maternity Midwifery Forum. Follow our websites, get our newsletters. You can look back through the back catalogue to see all the years that Alicia has been doing turns on this. And thanks to our speakers, and we'll see you soon.